hope this presentation will also appeal to you. So today we'll be talking about precocious puberty, which for pediatricians and even for general practitioners and for gynecologists is becoming an increasingly common issue and becoming very, very common in the pediatric office practice. This is for, yeah. So before we start, I think all of us have an idea about what is normal puberty. So the onset of true clinical puberty is in girls, it starts with the appearance of breast buds, and in boys it actually starts with the testicular enlargement. And the normal age of onset of puberty in girls is anywhere between 8 to 13 years with a mean of 10 and a half years, and in boys is between 9 to 14 years with a mean of about 11 and a half years. And when we talk of precocious puberty, we talk of the onset of any secondary sexual characteristics, whether it is just breasts or hair or enlargement in the penis size or the testis, any change before the age of 8 years in girls and before the age of 9 years in boys. And also an extended definition is if a girl has menarche before 9.5 years of age, it's considered too early and it is considered as a part of precocious puberty. Now it has been noted, and probably you people have also noticed in your clinics, that during COVID and during and after COVID, this incidence of precocious puberty has actually gone up almost 3 times. Although we don't have any prevalence studies in India, but some studies have been done in different parts of the world, including Italy, US, etc. And they have found that what are the reasons? Why is this trend becoming more and more common? So there is a direct relation with the increase in the BMI, which is because of increased intake and less output of energy of children during COVID time, sitting at home, eating mostly on screens, not moving around. So the increased BMI increases the leptin, and this is the leptin is one of the neuromarkers which actually increases or starts the switching on process of the pituitary gland and gives rise to this early puberty in girls, especially in girls. Increase in screen time. Now it's little confusing. How can screen time actually increase puberty? But what is being seen is that because of the blue light of the screens, there is a decreased production of melatonin, and melatonin is actually an inhibitor of the gonadotropin cells in the pituitary gland. So when there is less melatonin because of increased screen time, the pituitary gets switched on early. Vitamin D, as we know, now it started playing a role. We've started discovering roles of vitamin D in almost every physiological process in the body. Similarly, during COVID, when children were indoors and with the kind of pollution we have in Delhi and other aspects where vitamin D deficiency has become so common, again, vitamin D low levels itself is one of the stimulators or one of the beginners of puberty because of activating the pituitary gland early. And probably there has been some direct effect of the COVID virus itself on the hypothalamic pituitary gland, leading to early incidence of early switching on of the pubertal process and therefore precocious puberty. Now there has been a huge, controversy or a huge debate about, what is the role of endocrine disruptors in the process of or in the pathophysiology of early puberty. And we know that endocrine disruptors in the form of plastics, in the form of chemicals, in the forms of BPA, so many different types are all around in our environment. They are in the air, toxic gases, they are in the water, they are in our houses, they are in foods, they are in packets, they are in preservatives. Everywhere in today's environment, they are surrounded by these chemicals which are actually causing harm to all our endocrine organs, and there has never been actually any dose related or cause effect kind of study till now. But of late, there has been one study which has shown, actually it has shown that the girls and the children who start with puberty early, their urine levels of these chemicals are much higher than those who start puberty on time. So we do have some sort of evidence coming forward, which is scientific and it's a clinically based, evidence-based study. Now, just a short word about the types of puberty. I'm just going to be talking about two types. Where we classify puberty as either central precocious puberty or peripheral precocious puberty. Central, as the word says, is because of the premature activation of the hypothalamo-pituitary axis, and peripheral is because of the production of sex steroids from the gonads, either the testes or the ovaries, or from the adrenal glands. So the commonest cause of central precocious puberty is idiopathic, especially in girls, and central precocious puberty is again more common, much more common in girls as compared to boys. However, sometimes in boys, when we look at central precocious puberty, it could be because of tumors or any CNS insults. Amongst the peripheral causes in the testes, boys who present with peripheral precocious puberty in the form of penile enlargement or the presence of pubic axillary hair, it could be because of a tumor or this is also known as a gonadotropin independent precocious puberty. More commonly in boys, it's congenital adrenal hyperplasia, which presents as increased penile enlargement and pubic axillary hair, so peripheral precocious puberty. In girls, peripheral precocious puberty is much rarer, and amongst the rare causes which lead to this kind of presentation are hypothyroidism, ovarian cysts, and McCune-Albright syndrome, which again is a very rare cause, especially in the Indian scenario. Not to forget are HCG secreting tumors anywhere. They could be in the brain, like germinoma. They could be in the mediastinum. Again, these are reasons which can lead to a gonadotropin independent precocious peripheral precocious puberty. Now, what are the red flags on examination? So, if a girl is coming to you with more than one secondary sexual characteristics, that means she also has breast and also has the presence of pubic or axillary hair much before the age that she should, this is most probably a central precocious puberty because she has activation of both the estrogens as well as the adrenal gland with the androgens. If a boy comes to you with just penile enlargement without a testicular enlargement, means that there is exposure to testosterone but without the activation of the pituitary gland, because that would first cause testicular enlargement. So there is some source of androgens which is coming from a place other than the hypothalamic pituitary activation. If there is asymmetrical testes, could be pointing towards a tumor. If there is extensive pubic hair with probably in girls, with maybe if you can look for clitoromegaly, with clitoromegaly or increasing musculature, again look for a cause like a congenital adrenal hyperplasia, whether classical or non-classical. If a girl has menarche at only breast stage Tanner 1 or Tanner 2, this is discordant kind of puberty. This is not the usual progression of puberty. Again, you should have high index of suspicion to rule out causes of, which are causing estrogens without any central activation. Because if there is a central puberty, then there is a whole progression of Tanner 1, Tanner 2, and after Tanner 3 is when menarche occurs. If the girl has a lot of capillary spots, has any bony tenderness, and has come with cyclical bleeds with not a very increased breast size, then it's a good idea to rule out or suspect at least McCune-Albright syndrome. So once you have suspected a child to have precocious puberty, how do you proceed? So first is, of course, you have to confirm that there is actually, this is actually a case of precocious puberty. In girls, the examination of the vaginal mucosa is very good tool, and a vaginal mucosa which is pale is suggestive of estrogenization, which means that this girl has probably started with the estrogen exposure and puberty. If there is evidence of height acceleration, so the pediatricians present over here will be very familiar with the growth charts. So plotting the height of the child at every visit and then looking at whether the child's height is crossing the percentiles, much before it should actually cross, where the parents are actually very happy that the girl is becoming taller. But this should alert, just to look at the chart when there is a jump in the percentiles, should alert the pediatrician to the possibility of this girl actually starting with puberty, and Tanner staging therefore becomes compulsory for all girls after 5 years of age, because though they are tall at that time, but their epiphysis are also, their bone age is also advanced and they are likely to end up short. Sorry. So any bone age advancement, so bone age is the other investigation we do, or the first investigation we do. A bone age advancement of more than 1 standard deviation and the prediction of final adult height is how we proceed when we see a case of precocious puberty. Apart from ordering the gonadotropins, an LH level of more than 0.3 is almost diagnostic of the activation of the hypothalamic pituitary axis. We have certain criteria on ultrasound of the pelvis, the uterine size, the endometrial thickness, the fundus-cervical ratio, and the ovarian volumes. There are cutoffs for pre-pubertal and pubertal age groups, even in the Indian scenario. So all this is how we proceed. We first identify the case, then we confirm there is precocious puberty, then we do a bone age, and we do the biochemical investigations and ultrasound. Having done that, especially if you are looking at a case of peripheral precocious puberty where your gonadotropins are normal but there is increase in either the estrogen or the testosterone, again it's more common in boys, so you have to look at, try to find the etiology. In boys, as I said, the commonest cause is congenital adrenal hyperplasia, which may not be a salt-losing one, just a simple virilizing CAH. So, imaging of the abdomen for the adrenal glands or any tumor is important. A beta HCG and AFP in all boys with peripheral precocious puberty is mandatory. LH gene testing is for special cases, because here you can rule out a beta HCG secreting tumor. We've had a couple of cases with that. In girls, thyroid function tests and any ovarian cysts. Sometimes there can be functional ovarian cysts which can, for some time spurt out of estrogen, which can cause some endometrial lining and cyclical bleeds with a little bit of breast development, but this is self-limiting. When we identify any boy with a central precocious puberty, that is, this boy has got gonadotropins which are at the pubertal level and testosterone. In all boys, it is mandatory to do a MRI of the brain at the pituitary hypothalamic area, the sella. But in girls, you can, if you don't do an MRI in a girl who is more than 6 years of age, started with puberty, it is all right. It is not mandatory. But any girl less than 6 years is important. And one of the common causes we get is usually a hypothalamic hamartoma. So I'll just quickly rush through a few cases. This is a 2.5-year-old girl who came with complaints of increasing breast size and some pubic hair, as you can see in the picture. Her height and weight were above the 50th centile, and on Tanner staging she was breast stage 2 and pubic hair stage 2. Her bone age, so the next thing we did, so here, as I said, there are bones to features. There is Pilarki as well as Pibarki. So here the chances of having a CPP are very high. So when we did the gonadotropins, they were high. The estrogen was high. The bone age was advanced. She was 2.5 years only, and the bone age was 5.5 years. And the ultrasound, the uterine size was starting to be in the pubertal range, and ovaries were much bigger than what they should be for a 2.5-year-old girl. So this case was identified as a CPP. And what is the next thing we are going to do? As I said, any girl less than 6 years with CPP, a MRI sella has to be done and was found to have a hypothalamic hamartoma. This is another child, 16-month-old, with height and weight around the 50th centile with Tanner stage 2 of the breast, but there was no pubic or axillary hair. Bone age was slightly advanced, less than 1 standard deviation. The gonadotropins were normal, estrogen was slightly more, and thyroid function was normal. So here, ultrasound was also normal, and here, what are we looking at? So this is a case of premature Pilarki. Again, a common presentation in the OPDs in children, in girls, even to gynecologists sometimes. So it's a diagnosis of exclusion. You have to rule out a CPP and then label it as premature Pilarki. And these girls also need very close follow-up, because there is some chance of them converting into CPP. So, a lot of times, in cases of premature Pilarki, there can be asymmetrical breast development, as you can see in this case. And also a point to note is that the areola and the nipple usually are not, they do not get too much pigmented as they do in cases of central precocious puberty. So it's an incomplete variant, as I said. I think I will just jump to the next case. Just to say over here that when we talk of central precocious puberty or peripheral precocious puberty, they are the complete variants. Then we also have incomplete variants in forms of premature thelarchy, as I spoke, and premature puberty. So there are lots of times we see girls coming to us with, starting with pubic hair or axillary hair at the age of 5 or 6 years also. So in all these cases also, you have to rule out a central or a peripheral precocious puberty, and when no cause is found, then they are labeled as premature adrenarche and this or puberty, and this is a common occurrence especially in SGA children, SGA girls, and these girls also later on have a higher chance of developing PCOD. Of course, like premature thelarchy, even they are to be followed serially 6 months, every 6 months to see if there is development of any other pubertal features. Premature menarche is actually a misnomer. There is no term like this. This is isolated vaginal bleeding. Sometimes happens and could be because of foreign bodies, vulvovaginitis, sexual abuse, sometimes urethritis. Very rarely there are sometimes there are cases of ovarian cysts, as I said, where there is, these may be functional ovarian cysts or large ovarian cysts because of hypothyroidism per se, which can leak out estrogen, which can cause these intermittent bleeding episodes. And in my practice in the last year, I have seen 2 cases of actually mothers and parents crying foul about the child having bleeding episodically, and actually turned out to be Munchausen by proxy, and the mother was actually feigning it to attract family attention. So this is another girl, 7-year-old with menarche, but she's short. She's way short than what she should be at 7 years. Her height age is less than first percentile. And here you see she has breast Tanner stage 3, no pubic or axillary hair, and she's short with a bone age which is delayed. So usually girls with precocious puberty are taller with advanced bone ages, but if we encounter a picture like this, hypothyroidism is to be kept at the top of the list. And although in our practices in the cities we don't see such prolonged untreated kind of hypothyroidisms, but it is not so uncommon in the peripheries. Another girl, let's just look at this scenario. She's 7-year-old. Her height is 125 centimeters, weight is 30 kilos. She is so this is her height is around, look at the centile again, and her Tanner stage 3 breast she has, and she has a pubic hair which is again started. Her bone age is 9.5 years. So she's 7 years, 125 centimeters, not very tall, but a bone age which is 2.5 years more advanced. So her predicted adult height will actually become very less. And we can look at the gonadotropins, they are all well in the pubertal range. All her uterus size, everything is in the pubertal range, and MRI was done in this case, though it was not mandatory, which was normal. So this child is labeled as a central precocious puberty and started on treatment with GnRH analogs and has done well. Another similar case, you see another girl, 7-year-old, who's 128 centimeters. Her breast age is only 2. She's just started with breast budding, but she's less than 8 years, so classically she falls into the definition of precocious puberty. And her bone age is only 1 year advanced, so just around 1 SD more than her bone age that should be at that age, although her hormones are also pubertal, but they are just pubertal. So these children, when we plot them on the growth chart as I have shown you, the red arrow is for the bone age, and the blue dots are for her height. So if you see the difference between actually her height and her bone age is not too much, and she is predicted to have a pretty alright height as an adult, close to the mid-parental height. So an option of treatment can be given to these children, but it is not really mandatory, because most likely she would progress slowly, have a period around 10.5 years because of less bone age at this time, and probably does not warrant treatment. So just the same thing explained over here. Is the time up? Yeah.
Thank you. Dr.
So,
Manpreet, yeah, this case 5 number, you said this everything was almost within normal limit.
yes.
Why the patient came to us?
For the breast development at the
That
age
is-
of 7 years.
Okay.
For the breast development. They were concerned that the child had started the breast development. So we do have some markers like AMH and inhibin B. When we can do a ratio, we can find out whether this child is going to progress slowly or rapidly. Plus, you see if she's very tall and her adult height is not going to be compromised, even if her bone age is slightly ahead. And you see the uterus, you see everything. You can predict when the period will be. If it's around 10 and a half, 11 and it's acceptable, you don't need to treat.
Thank you, Dr. Manpreet.
Just one point that sometimes these girls come to your menarche. They come with menarche at 9 and a half, 10 years, and that time the bone age is already very ahead. So if we try to treat it with analogs, you want me to stop? That's it. I'm just trying to say that when they come very late, then you add growth hormone to the treatment, and then they do well in terms of height, adult height prediction. Both, because you need that time for the growth hormone to act. That the combined treatment is useful. Sorry? Dose of ALS depends upon the weight of the child also, and also depends upon what schedule you are following. So if you are giving monthly, it's 3.75 milligrams. If you are giving it 8 to 10 weekly, 11.25, and if you are giving it 3 monthly, it's 22.5. But weight-wise, so above 30-35 kilos, we give a higher dose.
What is the cost of a normal this child which we predicted around 7-8 years? What is the cost of growth hormone therapy and the duration? Most of us are interested in this.
The cost of growth hormone.
Hormones, yearly therapy, how much it cost?
Yeah, so see, today we are talking of precocious puberty. So the management of precocious puberty is analogs. So growth hormone only comes in when we are, somebody is coming very late to us. So let us talk about the cost of the analogs. So and the cost of the analogs again depends upon the company that you are taking it from. But roughly,
about the person who are concerned about the cost. Though, what is the minimum cost we can expect?
Yeah. The minimum cost you can give. I use 11.25. The minimum cost we can give is around 7,000 to 8,000 every 8 to 10 weeks.
That is acceptable.
Yeah.
That is acceptable.
On the higher side, 10,000.
Thank you so much.
So we give it. Usually we give it for a period of 2 years, usually we give it for a period of 2 years, or if the child has started at 5 or 6, then till she's about 10 years old.
Excuse me, you mentioned that you examine vaginally all the precocious puberty.
Yes. All cases.
All the precocious puberty.
I see you that we have short of time. You have to proceed with the next section, please.
Thank you, Dr. Manpreet.
Thank you.
I
It's a
request
nice presentation.
everyone,
Thank you
Dr.
so much.
Manpreet and the chairpersons to proceed to the felicitation count.